Michael, that was great. We're going to then have the con approach. Dr. Muehlebach is going to give the con approach. He is currently the director of cardiovascular surgery and lung surgery, coronary artery disease, heart valve surgery, and esophageal surgery at the University of Kansas Hospital. Thank you. You have a good job coming up.
I didn't see Jim Lear pulling them off at his 10 minutes. You know. Thanks for having me, and I'd like to thank DJ for throwing me up here in front of the conference for why we're all here to have this done. But first, we'll just take a quick show of hands for all this new technology and everything and all the enthusiasm. How many people have had this done? Yeah. So it's not the same enthusiasm that physicians have like at a urology conference. So, you know, there is physician participation is not quite there. So I'm going to go through the 10 reasons why you wouldn't do it surgically, or why you wouldn't do it maybe even non-surgically. And surgically becomes a little bit skewed here, because if you talk to Dr. Holmes here, nothing against his age, when he started in practice, I'll bet you he didn't do a whole lot of procedural-based things in his everyday practice compared to today's electrophysiologists who are almost every day in the lab. And is the lab the operating room? Well, that's all up for discussion. But so if you look at the cost, obviously we've gone through all these things about AFib and how many people have it and how it affects the population and what it's going to do to the population as the population grows. And I think that the thing that we begin to realize is that the cost of AFib is tremendous. And it's not just the cost of AFib for drugs, rate control, anticoagulation and whatnot, but it's the cost related to the complications like stroke. So if you look at those costs, it's very difficult to go through those costs and then say surgically, if you go and repair or close the atrial appendage on every patient that has surgery, are you going to make a difference in these costs? And I think it would be very, very difficult to prove that in this large number of patients that come along. And certainly we can affect a small number of people, but I'm not sure that we can affect a large number of people. And the other side of that is, you know, as this talk progresses, you'll see is what's the reimbursement for this? So the reimbursement for this in cardiac surgery is zip, none, zero. So if you're adding this on to a procedure, you're not getting paid for it. So the more you're using, the more you're doing, the reimbursement is going down, not necessarily to the surgeon, but the reimbursement to the hospital. We don't treat all our patients as if they're in AFib. So we don't do AFib ablation on every single surgery patient that we operate on, as Dr. Mack just said. 75% of them wouldn't need it, but 25% of them would. An AFib ablation with a clamp to the pulmonary veins, I can tell you, carries very, very little risk in the operating room. Is there less risk in the operating room of doing a clamp ablation of the pulmonary veins than there is to doing a ligation, exclusion, whatever it be, of the atrial appendage? I would argue that there is less risk with clamp atrial or pulmonary vein isolation than there is with ligation or removal of the atrial appendage. If you look at these patients and you say, well, there's lots of different patients that come into play here, the coronary artery bypass patients and the valvular heart disease and whatnot. The CHAD score is basically the same risk factors that surgeons look at every day for the risk of stroke and doing putting somebody on cardiopulmonary bypass. So the thing to remember here, the important part is the CHAD score looks at systemic factors. It does not look at left atrial size. It does not look at the left atrial appendage. It looks at systemic factors. And so those are the things that are putting us at risk for stroke. So that the left atrial appendage, although implicated and often the smoking gun, has not always been proven to be the case. So as we look at evolution, especially of cardiologists here, the cardiologists have gone from the internist to the cardiologist, and now they all think they're surgeons because they're in the operating room wearing hats and their mask comes down below, their nose is showing and their hair's hanging out. And, you know, I mean, it's unbelievable. But they've all progressed to being surgeons. But embryology has shown us that this is there for a reason. I mean, we still have 5 toes. We still have an appendix, and we still have the left atrial appendage. So I think we have to take into consideration that embryology here and the changes that occur are often beyond what we understand. And another very important point to understand with the embryology, which has been pointed out on several of the pictures and also discussed by Dr. Mack, which I think gets very quickly breezed over, is the circumflex coronary artery. And if that is injured during any of these procedures, I will tell you that that is a fatal event if not recognized. And it's not often quickly recognized. So that this is a very, very significant problem. Although not often reported, I think that the risk associated with this are significant and oftentimes overlooked. Not to bash on industry, but industry has somewhat pushed a lot of what's happening here. As we've already seen, the first left atrial appendage ligation occurred back in the late 40s and early 50s. We've had the ability to ligate the left atrial appendage for over 50 years. But it hasn't been until the last 10 years that we've really pushed to do this. And are we pushing to do this because now we can? Well, we've always been able to do it, but we're pushing to do it as surgeons, I think, more because our colleagues, the cardiologists, are also doing it. So if they can do it and we can do it, then we can do it better than they can do it, and so we're going to do it and they can't do it. I mean, I would argue as a surgeon, I'll tell my cardiology colleagues, my EP colleagues, I won't ligate any of them. You can do all of them later. Keep sending me the patients. My partner ligates them. Don't send them to him. You won't get them back. So there's always the argument of who's going to stay on top of that. The closure devices are, once again, the things that are driving us. So if we look at these closure devices, unfortunately, lots of surgeons have fallen into this trap of, well, you can use that in the lab. Maybe I can use that in the operating room. So instead of taking a $2 piece of Prolene suture, we've decided that we might want to try one of the devices that you guys use that costs several $1,000s. And we get pulled into these device, ideas like the lariat, the lasso. But as you tighten the lasso, I'm not sure it's a lasso or it's a noose. Because as you continue to use this, we have to look at what are the upfront risks of doing these procedures. I'm not talking about intervention, I'm talking about surgically. So that the upfront risk have to outweigh the ongoing risk. And I'm not sure there's any study that's ever going to be able to prove that. The late effects of doing this are also not documented and unknown. And as Dr. Mack referenced, the Mays patients, the early Mays patients that had true amputation of the appendages, had terrible problems with fluid retention. And many of the studies that look at those patients, even 2 years later, still had decreases in their atrial natriuretic peptides. They still had problems with thirst. They still had all these other issues. And finally, I would say, of the ones that you ligate as a surgeon, and you send them back to the cardiologist or your internist, and you say, oh, by the way, don't put them on Coumadin because I ligated the appendage. And they say, thank you very much. And you see them back, and guess what? They're on Coumadin. Who's going to take that risk? Who's going to be the one that says, you don't have to take Coumadin, that's me, I'm the one. And then when something happens, who's the fall guy? The surgical closures are very much up for debate, as we've seen. And the surgical closures really kind of started with these endoloops. And the endoloops were something that we got because we did laparoscopic surgery and we needed things for laparoscopic surgery. And once again, we start using this for that. And we developed the robot, then we got to figure out why we have the robot. So all these things kind of progress in somewhat of a backwards fashion. But the reality is if we keep going back to even the original record of this in 1948, it was amputation of the appendage that was done. But if you look at these procedures like amputation, if you ask any surgeon, what are you going to do and what are you worried about? The first thing I'm going to tell you is I'm worried about bleeding. And bleeding occurs with all closure devices, whether it be a suture, a stapler, an endoloop, no matter what, they all have bleeding complications. Once you've ligated, addressed, done anything to the atrial appendage, you're off bypass and the bleeding starts, it's very difficult to get back there and control it. So bleeding is a major, major concern. Bleeding becomes a bigger concern in the higher risk patients. So these little old ladies with these fragile atria, they fall right apart right in front of your face. As I said, injury to the circumflex is a very important part. There's been documented cases of patients doing open mitral valve repair replacement, closing the atrial appendage only to find out later they closed the pulmonary vein. And then there's also this disruption of the atrial endothelium that occurs when you do a closure of the intra-atrial closure of the atrial appendage, which still leaves these people with a thrombogenic risk. I'm not going to get into too much of the physiology and the atrial contraction part, but if you talk to people that really argue this, they're going to tell you that the left atrium is there for reasons that a lot of us don't really understand. And if we continue to ligate it, maybe we will find out why it's there. But clearly we've shown through the Mays procedure in retrospect, not moving forward, that these things occur. The atrial natriuretic peptide decreases. These patients have problems with thirst. There's animal models that show dogs won't drink. So there are other things that are affected that we really don't understand. And the surgical outcomes, I think, are the thing, from my standpoint, that really are not published, not out there enough for any of us to understand. And Dr. Mansour referenced the Cleveland Clinic article, which I think is a very interesting article to look at and kind of somewhat summarizes what's happened. So the Cleveland Clinic is very good at putting these types of articles out because they have 18 gazillion thousand patients they've operated on. But in this article, they looked at a 10-year period, 94 to 2004, or somewhere thereabouts. 2,400 patients during that time period, they have documented had left atrial appendage ligation exclusion removal. In that group, they reviewed, in that study, 137 patients. So follow-up, even at the Cleveland Clinic, is not very easy in these patients. And these were all patients that had TEE. And if you look at that group of patients and you separate what they had done, 40% had amputation and oversewing removal. And 60% had some other oversewing, exclusion by a stapler, or a staple without amputation. And as we saw in some of those results, if you look at that 60% that had oversewing, had staple devices, the staple device that does not amputate, all of those recanalized. If you look at the staple devices that amputate, and you look at the oversewing, 60% of those patients have either a tract, something else form, they have too big of a pocket, so many of those patients fail. But to me, the more interesting group is the group that has amputation. They cut it off and oversew it. And 40% of those fail. And if you look at those that fail, there's a significant number of those that, quote, have a new atrial appendage. Well, I'm not a very smart guy, but I can tell you, you don't grow an atrial appendage. That's called a pseudoaneurysm, and that's a problem. And the other thing in that group of patients is if you look, when they reviewed those patients, 11%, not statistically significant, but 11% of those patients had strokes with no evidence of left atrial clot, or they had complete occlusion, no source of clot in the left atrium. 11% of those patients that then presented later had strokes. So the number one reason is, I ain't going to pay you. So keep bringing it on. You can do all you want to do, but you aren't getting paid. But the number one reason is something I learned in my training careers with a pediatric heart surgeon, Keith. I can't believe I just lost his name. But anyway, told me that his young partner, when we do pediatric surgery, he would always remove the thymus, take it out, and off we go. And I said, well, Keith Ashcraft, I'm sorry. And I said, your partner always removes the thymus. Why don't you remove it? And he said, you know what, I may be an arrogant surgeon, but I'm not so arrogant as to believe that I'm smarter than the guy that put it there. Right.